Hello, everyone. In today's session, I wanted to do an introduction to uveitis as an overarching topic. I think there are general principles that apply across the board for uveitis, and of course there are exceptions. But I think it's useful to have a sort of framework when you're approaching patients with intraocular inflammation of any sort of severity, and it's useful to have a sort of underlying understanding of what it is that's going on and what could be going on that drives inflammation in the eye before in future sessions we go into specific syndromes. So uveitis is inflammation of your uvea. So that's your iris, your ciliary body, and your sort of choroid at the back. And there's lots of different ways to classify things, and we'll talk about them. We're going to touch on a sort of broad approach to the assessment of intraocular inflammation, how to investigate it, and then talk about isolated anterior uveitis and talk about the different sorts of multi-system diseases that exist as well. So your classification of uveitis, you can sort of classify it down to anatomy. So you've got anterior uveitis, which is typically iritis, an intermediate uveitis, and a posterior uveitis. And that sort of describes the three parts of your uvea, and then obviously a panuveitis, which is an amalgamation of everything. And you can also classify it according to etiology. So you've got infectious causes of uveitis, non-infectious causes of uveitis, things like masquerade uveitis or neoplastic sort of syndromes. So there are lots of ways to think about the classification of uveitis, and you'll come across different ways depending on what you're reading and the sort of subspecialty clinic that you're in. And you can sort of describe uveitis in certain ways. So there's sudden onset uveitis, more insidious onsets. There are limited courses of uveitis where you have it the once and then it goes away, persistent courses, and then you've got the differences between acute, recurrent, and chronic. So an acute uveitis is something that has a sudden onset, it's limited in its duration. And the difference between recurrent and chronic is specifically where recurrent is you have repeated episodes, but there is over 3 months of inactivity between episodes, and you're off treatment. Whereas with chronic, it's sort of persistent, or you have a relapse within 3 months of being off treatment. And that's a general understanding of how to think about recurrence versus chronic cases of uveitis. And then with your grading, you can look at flare, you can look at your amount of AC cells, and you can look at vitreous haze. And depending on what you're seeing in front of you, that then helps you understand how bad the flare is. There are specific definitions. So, for example, with the cells, you're looking specifically through a 1 mm by 1 mm slit beam across the anterior segment, anterior chamber, sorry. And with flare, you're kind of thinking, is there no flare at all, or is it so intense that you can barely even see the iris? For AC cells, is there, the odd trace cell, or are there over 50 within that 1 by 1 mm squared? And then with vitreous haze, again, is there none at all the way through to not even being able to see the optic disc through the vitreous haze? So there are different ways to grade uveitis. And there are lots of different differentials that you can think about, and you can sort of split them up. I've kind of like to think of them anatomically. So with anterior uveitis, you've got things like idiopathic disease, which is almost 50% or more of cases that you'll come across. There are infectious causes like the human herpes viruses, HSV, HZV, CMV, syphilis, Posner-Schlossman, which I think has an association with some of the herpetic viruses. And then inflammatory conditions like your HLA-B27 syndromes, juvenile idiopathic arthritis, Fuchs, heterochromic, sarcoid, for example, tubular interstitial nephritis with uveitis. So there's lots of things that can drive an anterior inflammation. Intermediate, again, idiopathic, and then you've got things like inflammatory conditions and infectious conditions again. In the posterior segment, so with retinal sort of vasculitis, you can think of focal idiopathic disease, toxoplasmosis. You've got multifocal diseases, again, idiopathic. Syphilis is a big one that causes lots of different things. And with the choroid, TB, idiopathic diseases, and then you've got all of the sort of white dot syndromes at the back that we'll talk about at a later date as well. And then panuveitis, again, idiopathic, but infectious causes tend to be things like endophthalmitis, for example, syphilis, TB, and then inflammatory conditions like sarcoid or Behçet's, or especially VKH. Now, the point of this slide is more to just sort of really broaden the mind in terms of what could be going on in the eye and what could be driving the eye. And where you then start to sort of narrow down depends on things like the history, the rest of the examination, the ocular history, the drug history of the patient. And that can help you sort of ascertain between these differentials what you think might be driving it. And of course, most of the cases that you'll come across are idiopathic, but it's important to have a good surgical sieve in your head in case there's something that's a bit of a red herring in the history. Now, when it comes to assessing a uveitis patient, the most important thing is obviously talking to the patient about how long they've had their symptoms for, and actually also what type of uveitis do they have. And what I mean here with type and length of symptoms is also what sort of symptoms do they have? Do they have problems, for example? Is it floaters that they're mainly noticing? Are we thinking this is more of a vitritis or a posterior segment issue? Do they have photophobia, which suggests that the iris is inflamed, or the ciliary body, for example? So, what sort of symptoms do they have? How long have they had them for? Have they had previous episodes of uveitis? Are they a known uveitis patient? Have they traveled anywhere exotic recently? Do they have a past medical history of, for example, sarcoid? Um, are they on any drugs, for example? Do they have any allergies? What sort of things are you looking at? And then with the ocular exam, you're looking at both the conjunctiva and the cornea. You're wanting to do a good anterior segment examination, looking at your angle as well for any evidence of the consequences of uveitis with PAS, for example. Um, Look at the iris, any transillumination defects, look at the lens, do they have a concurrent cataract? And then obviously try and get a vitreous and a fundal assessment as well, taking particular look at the disc and the retina. Is your disc swollen? Do you have any sort of retinal vasculitis associated with it as well? And when you don't have a view because of what's going on at the front or a dense cataract, you do want a B scan to know whether or not that uveitis is extending to the back. And then finally, you just also want to do a quick systemic review. And there are lots of associated diseases when it comes to your uveitis. So, when it comes to a systems review, are you going to do this with every single patient sat in front of you? No, not necessarily. But when you've got your recurrent cases and you've got somebody sat in front of you that looks a bit different to your usual case, you may want to do a quick little run through in terms of their systems. So, do they have any history of pericarditis, myocarditis? Do they have cardiac failure? Do they have any evidence of sarcoid, SLE? Do they have inflammatory bowel disease? Do they have any issues with the genitourinary system? Are you thinking it might be renal in origin, or do they have reactive arthritis? Do they have any ulcers in their mouth, for example? Any tinnitus in their ears that they can hear that might give you a suggestion of VKH? Are they HLA-B27 positive? Do they have JIA? Do they have TB? Are they do they have psoriasis, for example? And finally, again, any MS or any VKH. So there's lots of different questions that you can ask. But if you're also seeing any of these diagnoses in the patient's history, you might be thinking that actually what you're looking at is an extension of that. And where that's important is it may not necessarily change your acute management, but it definitely changes whether or not you think these patients need to be under a uveitis clinic or whether or not you can just treat and discharge. So when it comes to investigating uveitis, it tends to be reserved for when it's necessary. You're not going to send off absolutely everything for a patient that comes in with an initial episode, but that may depend on who you work for and where you work. You do want to consider your differentials. If you're thinking that there's an infective drive, you may want to consider doing different investigations, including biopsies. And quite often, it's just a clinical diagnosis. So you're just sort of seeing what's in front of you and treating it. And you only really start to investigate when they come in for their second or third episodes. And what can you send? So in uveitis, you can send off lots of bloods, looking at an FBC, CRP, ESR, a urine dip, and a chest X-ray. These are sort of your generic things that you can send off. You can also send off some specific bloods, ACE for your sarcoid, for example, ANCA, HLA-B27s, quantiferons, toxoplasmosa, plasmosis, serology. You can think of doing a CT, a lumbar puncture, an MRI, if you're thinking of any CNS origins. And then in terms of your ocular investigations, FFAs and ICGs can be very helpful for posterior segment inflammation. ERGs can help you know the potential of the retina as well, or in children, for example. A B scan can be helpful when you don't have a posterior segment examined, especially for the hypertensive uveitis. Sometimes what you might find is an aqueous sample can be helpful in the acute stage, because you can then send it off for serology looking for things like CMV, which can drive a hypertensive uveitis. But once you start to treat hypertensive uveitis and the inflammation settles, the what you can get from an aqueous sample tends to be less sensitive because you've already started to treat it. So when it comes to monitoring uveitis and how to manage it, you tend to monitor with sort of the systemic stuff, especially if you're thinking about starting the patient on things like oral steroids or, for example, immunosuppressants. So look at their blood pressure, what's their weight, their blood sugars, check their urine and their bloods, looking for their liver function. And then ocular exams, you may want to keep an eye on their OCT. One of the common complications of uveitis is things like CMO. Look at their retina. Think about doing any angiography if you feel like you need it. EDTs again if you feel like you need it, and fields, especially for when you've got a lot of choroiditis or retinal vasculitis and you're worried about their peripheral fields. And how you're going to manage, there are sort of medical and surgical measures. You can think about ocular and systemic immunosuppressants, and there's also intravitreal treatment. So, with the medical and surgical measures, so you're going to think about things like, are you going to treat it topically or do they need injections? Are you going to give immunosuppressants topically to the eye in the form of steroids, or will you give it systemically again with steroids or maybe even other immunosuppressants like mycophenolate, for example, or methotrexate? And then are you also going to consider giving them intravitreal treatment? So for non-infectious uveitis, you may even consider giving intravitreal steroids. And the complications, whenever you're asked about this or whenever you're thinking about this anterior segment, you can get band keratopathy quite commonly, which is obviously going to impact their vision if it crosses the visual axis. A cataract is very common. That's sometimes secondary to the uveitis or secondary to the treatment of uveitis with the steroids. And then with the posterior segment, again, uveitis can drive pressure. The treatment of uveitis can drive pressure. Uveitis itself can also drive CMO. It can cause retinal detachment, debris in the vitreous, giving the patient floaters. And it can also, with choroiditis, scar the macula, cause holes, ERMs. And so there's lots of complications that can happen in the posterior segment, which is why some of these patients, especially with the recurrent cases, need continuous monitoring of their posterior segment. So, in summary of just this sort of introduction to uveitis, we've talked about sort of how uveitis is discussed, how it's classified, how to sort of approach assessing an eye with intraocular inflammation, what to do when you're investigating uveitis, what you can think about sending off, how to monitor that disease when you're in a uveitis clinic, and how do you actually manage the disease just in a sort of broad sense. And in later sessions, we'll kind of go into the specifics of all of this. So if you don't mind just filling out some feedback for this initial session, and there'll be future sessions as well on more specific uveitis cases.